Okay, so the first question, were you present? It could be either the first or the second, so either 2011 or 2001. You can vote now, please. And on the top right-hand corner, we can see the number of voters. I think there are 150 voting pads or something. Okay, we are on 124. Okay, that's interesting. So the majority, it's the first time they attend. Next question. In what country do you have your primary practice? You see the numbers there. You can vote now. Okay, so 40% from Belgium, and so it's interesting. Last years we had about 60% from Belgium, so we're growing up to an international level. Next slide, primary discipline. I'm curious whether we would have any surgeons. We always have one or two. Okay, one surgeon probably. Can you please raise your hand? Who is the surgeon? Don't be afraid. Okay, give him an applause. Next question. Are you in training or are you qualified doctor, and how many years of qualification do you have? You can give a vote here. Okay, so we have a lot of experience, a lot of doctors above 15 years of experience, very wise audience. Next slide. So now we have the first question in a series. So this is about a patient with sepsis septic shock, and we want to know whether you're using one, starches, but with caution, normal saline and hypertonic albumin, balanced crystalloids, crystalloids and hypertonic albumin, gelatins, hypertonic solutions, or you don't treat septic patients. You can vote. And the next questions, it will be the same type of options. Okay. So, okay, we will discuss the results during the meeting for time's sake. Next question, so now we have a critically ill patient, but there is no sepsis, but tissue hypoperfusion. So maybe a patient with some hypovolemia, you can vote what you would choose. I think you realize that it's all about the discussion going on between the EMEA and the PRAC. We can continue to vote, so balanced solutions, I see the majority, but still 20% starches. So now you have a patient in the perioperative setting who is hypovolemic, hypotensive. So what would you use? You can vote. Okay. Okay, so now we see starches increasing and crystalloids balanced a bit decreasing. Next slide. So now we have a patient with major bleeding and trauma. You can vote. Okay, almost. Okay, so now the crystalloids are decreasing and starches are increasing, which is what we would suspect. Next slide. Now we have a patient with traumatic brain injury and hypoperfused. So maybe in the setting of increased pressures. So here, again, balanced solutions, and then the hypertonics are coming up. Next slide. So this is about a lecture on cardiac surgery. So what would you use as pump priming solution? You can vote. Of course, this is only related to doctors working in a cardiac surgery unit or a cardiac surgery ICU. Okay, so here again in favor of crystalloids. Parental nutrition, there's a lot of discussion going on. So here, would you add parenteral already from day one? from day 3, 7, or from day 7, except you start earlier if the patient is severe cachectic or suffering from malnutrition. Okay, so the majority would add it from day 3. Interesting. Next slide. So now, after the fluids, we will focus on monitoring. So what type of monitoring would you prefer in the early phase, so it's within the first minutes, hours? Would you just use clinical judgment, arterial line, central arterial line, uncalibrated cardiac output, or calibrated? You can vote here. So it's in the emergency room, first minutes to hours. Okay, so majority would directly go for A line and central line. Next slide. So now the patient goes to the OR or ICU, so it's the first 8 to 24 hours. What would you use in this setting? You can vote. Okay, so still in the operating theater, first 24 hours, majority CVC line, A line, and now we see an increase in cardiac output monitoring. Now we move on beyond the first day, so within the first week, let's say, so it's the late phase of shock. What would you use here if you have a problem with end organ perfusion or respiratory failure, kidney failure? So please vote. So after the initial resuscitation, what would be your choice? And very interesting results. So the majority would go for calibrated cardiac output. Next slide. So now we are in the late stage of the illness. So that's when we start thinking about de-escalation, so fluid removal. So the same question, would you need any type of monitoring? You can vote. And if you would like a monitor, which one would that be? I realize that not much of the audience trusts the clinical judgment. Okay, so here at the late stage, some mixed feelings. Next slide. So how do you assess fluid responsiveness? Or maybe you don't assess it, so you don't need fluid responsiveness. You do a fluid challenge and see what happens. You use functional hemodynamics, SVV, PPV, you do passive lag raising, or you do functional hemodynamics with a passive lag raising, or maybe something else, like end-expiratory occlusion. Please vote. So what do you use to assess fluid responsiveness? Okay. So I think here fluid challenge a lot, but also the combination of passive lag raising and functional hemodynamics. Next slide. So do you use cardiac ultrasound? You don't use it. Transthoracic, TE, or you use transthoracic and transesophageal. Please vote. Do you use cardiac ultrasound routinely to assess fluid status in critically ill patients? Okay, so 50-50. Next question. Regarding surviving sepsis campaign guidelines, we will have some lectures on that. They were updated. Is there something missing? No, they are perfect, and I use them. No, they are perfect, but I don't use them. No, but the CVP should be abandoned. Yes, there is something missing, volumetric preload. Cardiac output is missing. PPV, SVV is missing. Passive lag raising or cardiac output, PPV and passive lag raising are missing within these guidelines. Can you please give it a vote? Very interesting, and I thank you for this. This will sure be covered during the meeting. Next slide. And then there's been a lot of fuss going on with regard to the ARDS definitions, the Berlin update. So the same type of answers here. The Berlin definitions are perfect, and you use them or you don't use them. You think that something is missing, and this could be abdominal pressure, maybe, or esophageal pressure, maybe extravascular lung water or pulmonary vascular permeability index, maybe parameters for capillary leak and fluid balance, or a differentiation between primary and secondary ARDS. So you can vote now with regard to the new Berlin definitions, which are basically the old ones, but they now have skipped the term acute lung injury, and ARDS is graded within acute or less acute stages. Okay, interesting. Capillary leak, the main culprit for ARDS, should be somehow included as fluid balance. Next slide. I think this concludes the voting, so I will now move on to a brief introduction. This will be our new hospital from the Ziekenhuis Network Antwerp. At least that is what we've been promised within 2018. And you can see there is some waterfront, so we will be able to come there with the boat.
Welcome in Antwerp, one of the most exciting cities in Europe. Antwerp is Belgium's capital of art, food, diamonds and fashion. It's in this great city that we organize our International Fluid Academy Day.
Oops.
Welcome. You are with 332 people, doctors from all over the world. And we are again from more than 30 countries. Yeah, even 4 countries this time, from Australia, New Zealand, Uganda even. So we're very excited that the fluids topic is having so much big interest from all over the world.
So what you should know about the third meeting is that it will be a 2-day meeting to have more time for interaction and discussion, and mark your date on November 29th and 30th of next year.
Ik ga me volgend jaar zeker ook gaan doen. Dat weet ik al zeker.
We realize that the knowledge of fluids is a big problem. Lots of doctors make big errors in prescriptions, giving too much, giving the wrong fluids. So we wanted to organize this Congress to make a clear statement what to do and unravel all the mysteries that are going on.
We are happy that we had the most important top specialists of today on fluid management and hemodynamic monitoring. We have speakers from England, the Netherlands, France, Germany, even Israel.
Maybe that you have some déjà vu feeling, and this is perfectly normal if you see these kind of movies and pictures.
Did something funny happen? Yeah. You'd never know it.
A little bit of any kind of fluid is not bad, exactly as we can enjoy some coffee, some Coca-Cola, and some beer and some wine. But too much of any of these fluids can be bad as well. So it's the same thing for intravenous fluids and for oral fluid for you and I.
I couldn't agree less with Professor Jean-Louis Vincent that if you would start the day with a whiskey and go to sleep with a coffee would probably not be a good idea. We are here, well, to foster education and promote research within the field of fluid management and monitoring the critically ill by bringing together doctors, nurses from all over the world. And for that, we launched the website, and on the website, we will soon make available more possibilities for downloading articles and for going to our slide jar pages where you can search virtually all the slides. Now we already have 1,300 slides there. You can enter a search item, and then it'll directly move you to the presentation and to the actual slide, which you could download, not in PowerPoint, but for further use later on. So please visit the fluid.slidejar website. We launched the newsletter, and Some of you may have received these with, oh shit, sorry. Okay, I forgot to put off my own mobile. Everyone received the DVDs of the first and second iFAD meeting. And I have to make a small statement that the issue of fluids you're carrying in your bag will be the last issue. I resigned as editor-in-chief for various regions, and we're happy to launch the future journal with resuscitation fluids. So if you would receive an email, please ignore this. We're solving the problem. We have our sister society, the WSACS, and with also this society, we try to foster education and promote research on other fields. The first meeting, we had about 400 participants. Last year, it was about 500 participants coming from 28 countries. And for this year, we have to do the final statistics, but we will probably arrive around 550 participants coming from 45 countries from all the corners of the world. We have from Peru, Colombia, South Africa, the US, Australia, and so on. For the first time, we have an ultrasound course, which is taking place next doors. And during the coffee breaks, you can visit the ultrasound companies to see their machines. And tomorrow, when we still have some places, if you're interested to follow a course on peripherally inserted central lines, you can notice this at the registration desk. We are here because of the big studies, the Christmas trial, the 6S trial, the chest trial. Recently, we had the crystal study by Jilali Anand, and all these papers created kind of an earthquake. Meta-analyses have been published showing us or telling us that control treatment with crystalloids is better than using colloids and starches, also with regard to outcomes as renal replacement therapy. There has been a shock, and there has been in the news, and stock exchanges have changed based on these publications. And the European Medical Association Pharmacovigilance Committee recently published recommendations, and Dr. Van Regenmotter will go into detail, but some reviews afterwards tell us to abandon the use of starches, and we are here to solve this question whether or not this is the right way to go. There have even been written statements and counter-statements to the PRAC recommendations. So it's kind of getting to a religious level. It's kind of, we need to choose a side. So it's a religious thing. I don't think this is a good thing, and it's the way that we need to go to decide whether we belong for the starches or for the crystalloids. Two things are infinite, the universe and human stupidity. And only about the universe, Einstein was not sure. So I think we should stop here discussing, and maybe we should start doing something new, something else. Because when we look at fluids, it's the dose that makes the poison. And fluids should be seen as any other drug with indications, contraindications. So it's about the type of the fluids, the dose, the timing, and the speed of delivery that we should take into account, and maybe look at other things like the RELIEF trial, which will come out looking at restrictive versus liberal fluid therapy. So what about the sepsis guidelines? Is there something missing? You voted, and a lot of you voted that cardiac output may be missing because this is the main determinator of the definition of shock, which is an imbalance between oxygen delivery and consumption. So multi-society statement says that there are different kinds of medical knowledge, and each kind has various strengths and weaknesses, and no single source of medical knowledge is sufficient. And it reflects the swing of the pendulum away from rigidly adhering to evidence-based medicine, as Professor Perel has stated many, many times, and we will discuss this. I need to know for my patient 4 answers to 4 basic questions. Should I give fluids? Because the best fluids is probably the one that has not been given to the patients. When should I stop? Maybe I need to unload my patient. So it's all about the benefits of fluids, the risks of fluids, the benefits of unloading, and the risks. So we need to implement the recent surviving sepsis campaign guidelines at the bedside. Do they really suck? We will learn more about this later. We must also understand that preload is not the same as giving or not fluids, because preload can be high, normal, or low, and fluids can be increased, kept, or decreased. But regardless of the preload, all therapeutic options are possible, so we need to know fluid responsiveness. And then there is the ARDS definition. So the difference between Europe and the States is obvious. And when it comes to the definition, initially it's the one listed here. It has been revised by the Berlin group. There has been a consensus of 16 talking about respiratory monitoring. But the fact is that if you apply the definitions, you will miss 50% defined as not having ARDS, but they do have ARDS according to the definitions. So maybe the evidence of lung edema, and you voted that capillary leak is the culprit lesion, and this should be included into the definitions. A recent study showed that extravascular lung water and the pulmonary vascular permeability index has the best predictive power to define ARDS, as stated by Azriel Perel. This should be included in future definitions. Why? Any definition of ARDS should, by definition, include extravascular lung water, because the cardinal feature is the breach of the alveolar capillary barrier, and this leads to capillary leak. So we must, by all means, try to define this. So, to conclude, please join us for the satellite symposia by the industry, today on Friday, tomorrow on Saturday. Please join us for the oral presentations. We have 4 oral presentations, and they're eligible for a prize award, so that the room is not empty, but the rooms should be filled. And please join us for the poster sessions. They will take place in the main entrance at the 2 screens from 12:20 to 12:50. Fill in the survey, and you may win the iFAD iPad. Again, follow us on Twitter, post your questions, and we will try to interact as fast as possible. Just one more thing for the speakers, and I'm getting over my time. Previous meetings, we had timekeepers, so big guys. These were my 2 oldest sons taking Professor Vincent off the stage. Last year, even the organizer of the meeting wasn't free of getting taken off the stage. But this year, we just have the chairman, and we will have a time indicator on the screen. Social program, important. Tonight, we're invited at the beautiful town hall. This is complimentary, there is no cost. We still have 50 places left, so if you're interested for the opening reception, just register with Anne Bogarts, and you can join us. And tomorrow, we will have the gala dinner with all the nurses of the ICU who will...
We're excited about the Congress. Okay. And Antwerp wouldn't be the city of pleasure if we didn't end the day with a gala dinner and a splendid after party.
It was a top event and a perfect day.
And we hope to see you next year in Antwerp at the Radisson Blu.
Thank you for the love you brought my way.
We hope to see you next year. Cheers.
See you next year. Cheers.
That was wonderful.
Bravo!
I loved that.
Oh, it was great.
Well, it was pretty good.
Well, it wasn't bad.
Well, there were parts of it that weren't very good, though.
It could have been a lot better.
I didn't really like it.
It was pretty terrible.
It was bad.
It was awful.
It was terrible.
Get him away!
Hey, boo!
Boo!
Enjoy the 3rd iFAD. Welcome.